Good morning, and thank you for joining Connecting Michigan for Health Conference. I just wanted to welcome you all here. My name is Chris Bailey. I am the Director of Consumer Health Strategy for MiHIN. I'm excited about this event. I've been looking forward to it for several months now because there's some very interesting topics that are very timely for our discussion. My background is I've had the fortune of serving several roles, such as an analyst, project manager, lean process engineer, clinical applications and analytics director, and entrepreneur. I always say I'm passionate about convenient care delivery and motivated by the lack of it. I know everyone here is exceptionally busy, and we appreciate your presence. Healthcare is in the midst of an industry-wide digital transformation, which is leading to changes in how organizations think about the value of centralized data, resource optimization, changing patient expectations, and empowering patients with tools. Our session today will explore the potential conjoining of two market forces, specifically value-based care and digital consumer health. Our panelists will share their experience and insights on how digital consumer health is critical for delivering high quality, lower cost, convenient care. For clarity, we're referring to digital consumer health as anything, any product or service that includes synchronous, asynchronous, virtual visits, personal health records, remote patient monitoring, and interoperability, and not just turning a video link on. Before we review the agenda, I do need to acknowledge and thank Nazi and Katie at MiHIN for their professional persistence and patience in pulling this event together. Next slide, please. So our agenda, we're gonna talk about and recap our March 23rd session with Dr. Jeff Van Wingen, and then at 9:20 we will have our main panel, and we're going to be talking about value-based care and digital consumer health. We'll take a short break and then jump back into two different breakout sessions. These breakout sessions are going to be conversational and participatory. So we encourage people to speak up, share ideas, ask questions, and just enjoy the event. After that, we'll take another break, and then we'll have a summary of the breakout sessions, and then we'll close, and I'll share where we're going next with the Connecting Michigan for Health Conference. Next slide, please. For those of you who were not at the March 23rd event, Dr. Van Wingen is joined a private practice in Grand Rapids, Michigan. He served the same population of patients since completing his residency in 2000. He's affiliated with Michigan State University as a volunteer clinical faculty member. His teaching experiences included infectious disease curriculum, humanities, along with mentoring students in his office since 2007. Since 2015, Dr. Van Wingen has served as a medical director for West Michigan branch of Heartland Hospice and Home Care. He has worked closely with Forest View Psychiatric Hospital since 2003, overseeing medical care of patients seeking inpatient mental health care. I've known Jeff for a long time. Not only is he a great clinician, he's very thoughtful and intentional about how to use technology. And one thing Dr. Van Wingen often says, and I quote, "Communication done right is at the root of almost every positive experience in medicine. Conversely, communication done wrong is at the root of most every negative experience in medicine." So next slide, please. And just real quick, the purpose of that session, that kickoff session for the conference, was just to sort of recap and reset where we are and where we came from when it comes to patient care and digital care within the pandemic. So Dr. Van Wingen, if you want to jump in and recap some of the lessons learned and insights you gained from the last year of the pandemic.
Sure, you bet. Hi, Chris. Hi, everybody. Well, here we are. Wow, here we are. And I think my experience with telehealth and technology-based medicine has really come through such a gamut. Years prior, my passion for telehealth was actually born out of doing medical work in India. And when I came back to the States, I really needed something to help me keep my finger on the pulse and continue to help on the other side of the world. So cobbling together Skype and the technology that we had available at the time, I really provided rudimentary telehealth. And pre-COVID, we had actually brought in telehealth to our practice, and I would say that we were dabbling, and really starting to really explore this in the beginning stages. But enter the COVID pandemic, and overnight the house was burning. And I can truly say that telehealth, it saved our bacon during the COVID pandemic as a primary care physician on a couple levels. And number one, it was a lifeline for communication with our patients, and in caring for our patients. It also it kept us afloat financially, with revenue in stream that allowed us to continue to really keep the lights on. And looking back, I think kind of philosophizing about how telehealth was able to accomplish that, it really broke the barrier to us seeing patients in a time when literally sharing the air with people around you could have potentially serious consequences. And here we are now, though. I mean, we've all got our COVID stories, but we're here and now, emerging into a brighter time. And I think this is an important time, and this is a really timely debate to come together with all of you from your respective specialties and interests to continue to take this football and move it forward. Because telehealth is still breaking down barriers for me in my practice today, but they look a little different. Things like this week, someone calling in with a bad rash, but trouble is they're camping up in Traverse City. Well, enter telehealth. We could convene with that person, whether they were in their camper or on the beach, literally to provide medical care, look at that rash and take care of it efficiently. If you think about old school, what might have happened is we may have sent them to an urgent care where they would have interrupted a good half day of their vacation sitting in a waiting room, in a place that was really foreign to them and uncomfortable. And we could really come in, use technology, use telehealth, and save the day. And really, we have countless stories and tales like that. And that's the kind of stuff that's really tangible that we can really see as a possibility, as a potential for current telehealth use. But I'm going to push the envelope here for you all today, because we've tested the waters and we appreciate telehealth. But now that we've recognized it as an important and as an enduring tool, we need to take it further. We need to do more, and we need to explore all of the capabilities and the potential implications that we have. Well, things like chronic disease management. We can move from the acute in the here and now, and just like I had done before, Skype with medicine. We can now use this technology to begin to manage chronic medical disease on a more in-depth basis than we could here in the office, because we can break down those barriers to personal contact. Primary care collaboration for hospital patients, convening the hospitalists and the primary care doctors with video as the patient sits in their hospital room is something that is untapped and unexplored, and can truly enhance communication and in turn the care and transition of that patient's health care. Case management with enhanced abilities that we would now have for video chatting with our RN case managers and our social worker case managers. These are just a few implications off the top of the head of a primary care physician, but we really need to pick this up, and that's the important place that we're at. We are truly at a crossroads of our future, and I think that's presently where we are at these crossroads, and we can dream it and we can do it. Chris, anything to weigh in from here?
No, just a couple questions. We're sort of on the other side of some level of behavior change. you've been in private practice for a number of years, and you've always been a trailblazer when it comes to technology. But I know your office, hasn't, and other providers haven't, right? So you jumped into this right away, experimented with it, and perfected your experience with it. What was the experience for other partners, and what is the lesson learned? Because I do believe there was a lot of fear and trepidation, and it turned pretty quickly. And so tell us about that experience.
Yeah, old dogs and new tricks, or just the notion that telehealth is not as good as in-person care. Well, I think that notion needs to be put into context. I'll say it that a telehealth visit is not always the same as an in-person visit. But when you have those barriers and you're there facing nothing versus something, we can really make something of what we have. And as far as the technology and the toggling back and forth between seeing a patient on the video monitor versus seeing a patient face to face, that's something that we've all reckoned with, and something that we've stumbled. But most all primary care physicians and primary care offices, and I would say even specialty offices, have this down and have their own personal regimen in place for this to happen. And I think branching out into those areas of care that I had mentioned might have a little bit of growing pain, but I think they're going to be necessary with the overall goal of improving communication and thereby improving care of patients.
As far as the the technology experience and that behavior change, that was a big change, because prior to the pandemic, a lot of clinicians didn't even attempt to learn the technology or experience it because there were payment issues and fear of quality interactions. So obviously the pandemic catalyzed that involvement. But as we look forward into the next year and several years ahead, we want to learn something from this behavior change, and how can we apply that to using this technology to do more than just turn a video visit on? How do you think we should approach that with clinicians who are still pretty immature when it comes to the use of care delivery using technology like this?
Yeah, those are great questions, and it really blows the mind to think about how quickly that change happened. It really took something cataclysmic like COVID to change a whole field that changes very, very slowly, very, very skeptically sometimes, and with a lot of policy wavering. But really, things happened at warp speed. Literally overnight, the doors were open for us to receive very generous payment for telehealth, and I think those market forces were enough to drive a lot of people to telehealth. But they're still there, and I think as far as moving the field to capture that revenue is going to be the most motivating thing to drive this change.
Yeah. I just remember because we've worked together, and I've always trusted your input. You've been a clinician at the other hand, and I've had the fortune of using you in a couple emergencies, and so just want to share that with the group. It's exciting when your son is in Central America, and your provider is on vacation on an island in northern Michigan, and when you need something really quick, you can make that digital connection, assess it, and treat it from two distant sites like that. Or when you're returning a rental car from a business trip and you get a phone call from your wife that the friend's dog has bit your daughter, and what do you do about it? So we've experienced it firsthand, the convenience of it, and I hope providers feel like this is a a valuable tool that makes their patients that much more confident in the care they're getting.
That's a great point, Chris. And, as we wrap this up, I think it's an important point to note that you've tasted this personally. You've tasted that convenience of receiving medical care on the fly during your busy life, and you haven't interrupted a good half day driving yourself or a loved one to a doctor's office or a ready care, and waited in the waiting room, and gone through the office visit, and then driven back and then re-engaged with your life. Patients aren't going to want to go back to that. And it really is about the patients, and we serve our patients. That's our primary focus. And patients are going to be a demanding force and not want to go back to that, the old way of doing things. Granted, there are a lot of things that really need to be done in the office. There are a lot of things that truly don't. And there's a lot of ways that we can reach out and touch our patients virtually that are going to need to be explored as we move forward.
Absolutely. One more, I saw a comment come in, and I think it's just worth mentioning, putting one more plug in, because I didn't think of it this way. Access to mental health, right? Just like access to, treating a dog bite or a stomach ache from Central America. Access to mental health. It's not just the rural distant sites that make it difficult to travel, but the concern about being seen in a mental health clinic. This gives folks the ability to do that from the privacy of their own home, and hopefully that improves access and use of mental health clinics.
That's a great comment, Deb, and I totally agree. And we've explored that at Forest View. There are so many ways that we can, and we've got a talented group that's listening in here today with a lot of background, a lot of depth, a lot of breadth in the medical field. And it's really time for us to start thinking and exploring that at this crossroads to really enhance medicine moving forward. This is a very exciting time. And if we can dream it, we can do it. The technology's there. All these factors are in place thanks to COVID as we move forward. And we got to pick it up, and we got to move with it.
Certainly transformation. Well, we are on to our next one. Thank you, Dr. Van Wingen, for jumping in and recapping. Appreciate everything you do. Keep pushing us.
It's a pleasure, Chris. Good seeing you.
Yeah, thank you. Yes, so our next panel discussion, I'll introduce them here, but I just want to share, that last picture. Dr. Van Wingen put that slide deck together, and that was a crossroads there. And so I was thinking about that. I was up last week, and I think I was just trying to veg out, and I saw Castaway, and it immediately reminded me of that final scene in Castaway where with Tom Hanks, after a period of loss and hardship and change, Hanks is looking at the map on the hood of his car in the middle of the beautiful open heartland. And a lady pulls up and says, "You look lost." And Hanks replies surprisingly, "I do?" The lady then asks, "Where are you headed?" And Hanks replies, "I was just about to figure that out." And it just made me think, like Hanks in the movie, he wasn't lost. We are not lost in this industry. We know where we need to go. Instead, I think we're collectively deciding how hard we're going to embrace the transformation to digital health and virtual care delivery. And I think that's the crossroads we're at. We all know where this needs to go. We're taking a break and waiting to decide how hard we're going to push in that direction. So I think prior to the pandemic, conjoining of value-based care and virtual consumer health would have been, an aspirational conversation. But today, I think we've hit a minimum threshold needed for behavior change. So the topics I would like to explore with our awesome panelists is, what are the behaviors and generational norms needed to embrace or be corrected with regard to clinicians and patients? we've got the technology, we've got the payment models, we've got good clinical processes, but we need to change some behavior with patients and with providers. And then the second topic I'd like to explore is what levers do payers, providers, policymakers, and vendors have to engage patients and drive equitable participation? If we think about a stool, I was thinking a 3-legged stool, but I think it's a 4-legged stool. I think it's the providers, the payers, technology vendors, and patients. And they need to be equitable or it's going to be unstable and wobble. And so that's what we want to try and achieve. So I'm going to ask, after I introduce our panelists, I'm going to ask them to spend about 5 minutes expanding on their organizations and how they're supporting value-based care and virtual health. Each one of these panelists are thought leaders, extremely accomplished in their field, and have different perspectives. And we will save the last 10 minutes of the session for questions and answers. So, honored to get into this. Anish Chopra. Anish is the president of Care Journey, an open data membership service building a trusted, transparent rating system for physicians, networks, facilities, and markets on the move to value. He served as the first U.S. Chief Technology Officer under President Obama in 2014. He's authored Innovative State, How New Technologies Can Transform Government. He serves on the board of the Healthcare Cost Institute, the New Jersey Innovation Institute, and earned his MPP from Harvard Kennedy School and a BA from Johns Hopkins. Thanks, Anish, for joining. It's an honor. I think you might be on mute.
Good morning. Can you hear me?
Yes. Thank you for joining.
Okay.
Our next panelist is Eva Matashevsky.
My audio fell off a little bit. Hold on one second.
Sure. While Anish gets his audio, I'll introduce our next panelist, Eva Matashevsky. Eva is a CEO and co-founder of MedNet One. Under her direction, MedNet One is a leader in advancing and development and implementation of patient-centered medical home and other advanced primary care initiatives involving physicians and their practice teams. Eva is also a founding principal of the Michigan-based IACET accredited healthcare learning organization, Practice Transformation Institute, which designs, develops, and delivers educational programs introducing the 21st century model of care to the healthcare community and medical practice teams. Eva is extremely passionate, and I know, like all of our panelists, is answering emails at 2 in the morning. So welcome, Eva. Thank you for joining.
Thank you, Chris. Really appreciate the invitation and the opportunity to share some information with the panelists and also with the participants.
Thank you. Dr. Amy Mckinsey. She is our next panelist I'd like to introduce. Dr. Mckenzie is a board-certified family medicine physician. She has 13 years of experience in private practice and over 7 years of experience in healthcare administration and clinical leadership. Dr. Mckenzie joined Blue Cross Blue Shield of Michigan in 2013 as a physician consultant supporting quality management and accreditation. She is now the Associate Chief Medical Officer leading provider engagement. Dr. Mckenzie also serves on the State of Michigan Certificate of Need Commission and was a former board member and president of the Michigan Academy for Family Practice Foundation. Thank you, Dr. Mckenzie, for joining.
Thanks for having me. I'm excited to be here today.
Thank you. I know Dr. Mckenzie from previous conversations. She's incredibly passionate about provider engagement. So we look forward to hearing her thoughts on how we increase good behaviors and the right clinical workflow. Last but not least, Dr. Con Ned. Dr. Con Ned is an internal medicine physician, community leader, and entrepreneur and researcher. He presently serves as the CEO of Answer Health. He is also the president and owner of Infusions Associates. Dr. Ned is renowned for his work around building strong communities and for his work addressing healthcare disparities. He has spoken and written extensively on the issues of healthcare diversity. Dr. Ned is also one of the founders of Grand Rapids African American Institute for Health, a West Michigan organization addressing healthcare disparities, utilizing a three-pronged approach to education, research, and advocacy. Thank you for joining, Dr. Ned.
Yeah, thank you for having me. Look forward to the discussion here today.
Yeah. So I'd like to just, like I said, all of you have made incredible contributions in this space, and some directly with your businesses, your organizations, but some through your volunteer work. So if we start with Anish, I know you've had quite a career. You're involved in as an owner and Care Journey, as well as a Caring Alliance. So we'd love to hear and have you share a little bit about why that's important for what we need to do and how we need to transform healthcare.
Thank you, Chris. How's my audio? You can hear me okay?
Perfect. Yes.
Thank you. Well, a real pleasure to join my colleagues on the panel today. I served in the Obama administration as Chief Technology Officer, and I thought I'd maybe set the stage broader, and then we can come down to the narrow role that I play today. As you recall, the administration had focused on improving access to healthcare, but also to rein in some of the excess inflation rates in healthcare through a number of experiments, not the least of which was the Medicare Innovation Center, focused on ways we could use incentives for the discussion we're going to have today to drive better clinical outcomes for patients. And the theory of change had been that each dollar of excess spend in health inflation was taxing our capacity to compete in a global marketplace. And so thinking, my broader role as CTO, America's response to China to retain economic competitiveness in large part is contingent on our ability to rein in excess health inflation. So this either is going to happen in one of two ways. We're either going to constrain it by slashing rates to doctors and hospitals and community centers and just putting healthcare on a budget, assuming that somehow miraculously it's going to automatically get better. Or we're going to actually invent a better way of delivering care, perhaps with the discussion of today, incorporating virtual and value-based care in order to hopefully accomplish the objective, which is more value for less investment. And we believe, I'm on a team value-based care, that there's the path in front of us is more prominent if we can actually get the system to test, validate, and scale what works. Now, the theory of change that I focused on from the technology perspective was that if we opened up data to shine light on what works and what doesn't work, in other words, democratize the way the system operates today, and we encouraged a kind of a person-centered longitudinal record that had decision support running, identifying areas in which individuals could more thoughtfully engage the healthcare system to manage their chronic conditions, and rewarded the organizations or networks that put these pieces together. That combination of initiatives would be the secret sauce or the active ingredients for a value-based model that lowers that inflation rate and improves quality. Care Journey, what I spend my time on today, and the Caring Alliance and some of the Smart on Fire areas that are sort of industry bodies that I serve on, is all about making sure that we have the right data, standards, technical infrastructure, and open platforms so our highly fragmented healthcare system can lift up together, and that we don't have a world where only a few well-resourced organizations can invest in the future and the rest of us are scrambling to make it happen. We've got to find a way to lift everyone, and I believe a lot of that is going to come from public-private collaboration on the use of data, on the interoperability standards that have come to market, and make the big programs, the public programs, engines of change on payment models that work. So that's where I spend most of my time, making sure that we can lift the industry up together on this very important journey that we're going to dive into today. So thank you.
Yeah, thank you for just a quick plug to that. I remember in my MBA class, one of the final sessions, we had the chairman of the Michigan Manufacturers Association come in and speak to us. And he said, if you want to do one thing, there's only one thing you need to do for us to compete, and that is lower the cost of healthcare. Because without that, there's no competition. So important point. I'm glad you brought that up. It's very relevant to everything we're doing in healthcare. So thank you. Eva, I know you have your hands full on so many different programs. And you've been doing that for years. Tell us about some of the things you're working on. I know your organization won an award for a demonstration site for it's called the Certified Community Behavioral Health Clinic. So I know you're working hard to change behaviors and change patient workflows.
So I think I need to start with a little bit of historical background for the group. So Medical Network One was originally formed to serve as the contracting agent for managed care organizations. And I won't tell you how long ago that was because it would really age me. But I will say this, as the result of that opportunity, we were also allowed the opportunity of becoming a third-party administrator in Michigan. So we were able to process our own med-surg claims and our own psych claims going back to around the Y2K era. And what we discovered back then, since we had all of this data, we were back then able to already identify some of our pain points in regards to diabetes, in regards to obesity and heart failure. So imagine that's about 20 years ago. And the system that we had was pretty archaic, but it really served us well. It allowed us to begin to think about tomorrow. So we began visioning the future probably in a different way than many of our colleagues did. And then I have to say this, the trajectory changed when we decided to engage in the physician group incentive program at Blue Cross. They really were the catalyst for allowing us to expand our IT capabilities and to really begin looking at care teams. So before we even, the community in Michigan thought of care teams, we already had travel teams in place, going into physician practices, doing QI activities, providing those dietitians, providing health coaches and other types of support services that were needed. But then once the funding started coming in, specifically from our colleagues on the Detroit River, we were able to expand our offerings in the IT world. We jumped into a patient registry. We jumped into a patient portal. And I have to say this, the average age of our physicians was not in the 30s or 40s. The average age of our physicians currently is actually in the mid 50s. And so as we began to look at what we could do to support, we found that it wasn't just the medical side we needed to bridge into the behavior health side. So as you mentioned earlier, we are part of the Certified Community Behavior Health entity in Southeast Michigan. Our partners are Judson Health Center. We have all sorts of agreements with community organizations. And one of our other branches of work is at the Salvation Army Harbor Light, where we also work in the area of inpatient rehab. And if it wouldn't be for telehealth, and if it wouldn't be for ADT feeds, and if it wouldn't be for people that were changing their culture and their behavior, we wouldn't be where we are today.
Thank you. And one of the words you said jumped out at me, and I just want to sort of underscore that and ask Dr. Ned when we get into our first topic. The use of health coaches, thinking outside of using traditional resources. The question I always had is, do we need to change the way people, the traditional care delivery resources work, or do we need to add care delivery resources and take some additional responsibilities away and really resize how resources are doing what? So, a question for kind of our first topic on behavior change. So thank you, Eva. Next is Dr. Mckenzie. Again, I know there's a lot going on at Blue Cross. I enjoyed hearing about Blueprint, so hopefully you can tell us a little bit about what that program looks like.
Yeah, thanks, Chris. Everybody can hear me? Yeah, good. Okay. So, you mentioned Blueprint. That's, a continued evolution that we have at Blue Cross around value-based care, which started, as Eva mentioned, with the physician group incentive program. as a foundational component. And we've been on this journey with our provider partners here in Michigan for 10 plus years. And if you include the collaborative quality initiatives, it goes back 20 years when you're going back looking at evolving that care model. So Blueprint is the latest evolution in that value-based. It's basically creating this shared accountability between the plan, the payers, our employer groups, and our providers around managing populations with both upside potential as well as downside potential. In creating that again, that those joint efforts and shared kind of vision and accountability for the future. As I look at Blueprint, though we talked a little bit about care models, it's really the care model evolution that sits underneath those payment models that, continues to support that moving forward. Some of that is enabled by digital and how we move forward. And you think about how that's going to provide access for patients who, may not have been able to engage, how it's also going to help enable some care models into the future around delivering care at home and delivering care in the way that people would like to receive it, and how we're able to tackle this mounting issue of cost that yourself and Anish brought up around addressing rising chronic conditions as well as an aging population. I was preparing for a talk a couple weeks back, and it's really now 60% of people in our country that have one of the top 5 chronic conditions, and rising obesity rates are continuing to drive that. And it's 1.5 trillion annually. And by 2050, they're predicting that it'll be 6 trillion. And so we have to continue to evolve the way that the care model works in this country in order to get individuals engaged in their own care and activated and able to overcome some barriers that they've had. I think, when I was training in residency, the common thing was, well, the patient's non-compliant. I think we've moved from that to understanding people have barriers to receiving care, right? If I'm working 2 jobs, I may not have time to get into the provider. And so you start looking at virtual care and digital technologies and how those are going to continue to evolve our own abilities to better meet patients' needs and deliver that care.
Yeah, no, I appreciate that. I lost my train of thought. I was going to ask you something, but I will come back to it. Oh no, I remember now. I want to put a plug in for some of the other great work that Blue Cross is doing that I think physician organizations have and will benefit from, and that's some of your innovations, your PCHIP innovations. That is an exciting program that you have, and if you feel free to talk about it, I'll share with what I know, but the ability to sort of seed ideas and hypotheses so that clinicians can have the freedom to design care models and test hypotheses out to see if they work. And if they do, share that with the rest of the community. I think it's a wonderful program. I don't know if there's anything to add to that.
Can I add something to that? I think it's beyond just seeding. They actually assist in the sprouting to make sure that it moves and it grows. So seed and sprout.
Good catch.
Yeah, I agree. We know that providers who are on the ground delivering care are in the best position to see where the issues are and to help us evolve the care model. And so I do think that those innovations programs, and then we learn from that. We learn from the providers what they're finding and what's helpful, and then we can help them bring that to scale and share that with partners across the state. And that's been really, I think, the success of where Value Partnerships in Blue Cross has been.
Yeah, it's a great segue into Dr. Ned, because if payers don't get involved, the industry will do it themselves. And Dr. Ned is an entrepreneur. I hope he talks about both Answer Health, some of the things going on there, as well as the work that he's done and achieved through Infusion Associates and how that's impacted cost and quality and experience. So, Dr. Ned.
Yeah, thanks. In my role, I like the term that Dr. Mckenzie spoke of, which is an evolving process. And I think when I think of my purpose, I've been an independent physician for most of my life, and I've always felt that that's a space that allows me to innovate, to constantly look at new ways of doing things. And so most of my businesses that I have been part of have always been based on a value-based principle. By the way, I think the value-based principle, is not new. It's been around for a long time. I just think we have not been able to elaborate and bring it to its full, potential. And we are going to continually trying to do so. I think when I think about, this healthcare model, I mean, at the end of the day, for me, it's an upside down pyramid where I think actually patients and our clients kind of really drive, healthcare. And they do it in the same way they do it in industry. I mean, we all know that there was a time when, Amazon, used to just sell books or whatever. And we as clients have, certainly, driven this differently, to where we can have, books that are in Kindle and all kinds of places. We can certainly stream movies rather than going to the movie theater. I mean, we are driving cars that can tell us where we are going. I mean, even in medicine, patients are more and more going to Google and looking for alternative ways of caring for themselves, and to some degree are moving away from what conventional medicine is. I mean, we see it, you don't have to wait for your grandpa, who's a carpenter, to help you build a shelf. You can Google and figure it out, and do it yourself, how to lay tiles or whatever you do. And I think that's, in healthcare, I think we have been rather static and kind of been lagging behind in that the conceptual view of how we deliver care is based on the physician-provider model. You come to me and I will treat you. And the consequence of that is that we have developed an ecosystem where a payment model kind of fits that. And as we have been trying to emerge from that, whether it's fee-for-service, the value-based, I think to some degree, health plans and others, have said, okay, well, how do I shift and change physicians in their thinking? And we decide, well, let's incentivize them by doing certain things so that they follow that. And when we achieve that, we go to another incentive and so forth and so forth. And I think that's still an archaic model. I think at the end of the day, I think what we want is to have patients, integrate with the value of what they believe is, promotes healthier living, a good, life and health. And how do we get there? And to some degree, I think we have to allow them to really drive that. And I think you're going to see these nominal changes that are becoming prevalent in healthcare, where the patient is going to really drive their care. And we are going to have to be on the open and responsive side to start figuring out how do we get it to them differently. Just before we got on the program, I was listening in the window to Dr. Van Winkle was talking about, some of the issues around, because I see it all the time, I hear it all the time, the pushback that physicians have to telehealth or to other, modalities, in technology that we can already use to improve the care to our patients. So I am much more open in terms of my sense of saying is that I'm going to let the patient lead to some degree, and I'm going to try to make sure that my service evolves, in a way that, I can accommodate what their needs are.
And so, thinking about Infusion Associates, I remember the days being in an ACO that lost the hospital, the PHO lost their patients to your infusion clinic because instead of you saying, patient, come meet me, you went out and said, I'll meet you halfway at a place that was convenient and lower cost. Instead of having them, make their way through the landscape of the hospital for infusion. And it was kind of ironic. The actual ACO arm of the organization said this is actually good because from an ACO perspective, this is better for cost for us. And it certainly didn't help hospital revenue, but it's a good example of finding ways to go out and meet the patient where at least halfway where they are. So.
No, I think you're absolutely correct. I mean, one of the things when I started Infusion Associates, I saw the business case, I saw all the other pieces, but one of the things that to me that really drove me the most was this value-based principle. As an infusion, we own outpatient infusion centers. We have 5 in Michigan, and we have 3 or 4 more coming up on the east side of the state. And one of the things that I kind of realized really quickly is that if you look at the ecosystem of healthcare, I was seeing a patient more often than the primary care doc was seeing them, and I was seeing them more often than the specialists who were sending them to me, which means that the touch points that I have, where a patient is sitting in a chair for 1 to 2 hours, in terms of the impact that can have on him or her, in terms of changing behavior, addressing all the other issues that are part of, the bigger picture of what the landscape of healthcare and how to navigate within healthcare. As a matter of fact, one of the things that I do now, I decide that I tell our employees that everybody who we interview for an employee, I tell them, theoretically, you are a care manager. If you see something, you say something. If you hear something, you talk about it. Because the opportunity, whether it's in, teaching we have pharmacists that we can educate our patients and, how to, deal with their medicines. Mm-hmm. If we see somebody, who's having an issue, they're more likely to tell the nurses. We can prevent an ER visit. We have a provider on staff that can communicate with that primary care doc and so forth. So it's really about taking your practice and saying, how do you, embed yourself within the greater landscape of the outcomes for these patients so you can be truly impactful. Now, the question is always most of the things that you do, you don't get paid for. But the idea is that if you get yourself entrenched in helping patients and how to navigate, true healthcare, then it becomes sooner or later. I think that's the thing about opportunity. You can't shut the door on it and you can't close the window on it. It will find a way out. So I think the more we kind of, take that perspective to healthcare, I think it's the better it is for all of us.
Yeah, this is so appreciate the background. There's a lot of folks here in the audience, and I think they're probably well represented from policy to payers to healthcare clinicians, technologists. As Dr. Van Wingen stated, and you all attest to, we're in this space, I think, that we just have to make that commitment and move forward and not lose the opportunity that a tragedy presented us. And I wonder what are, I'd love to hear each of your opinions on, we have to change some behavior. We have to create new generational norms of how we deliver care, who delivers care, and how patients access it, right? There's issues with patient literacy. If your patient isn't literate, if they think that eating a box of granola bars for Nutri-Grain bars for dinners is a healthy choice, then we're going to have real problems. If your clinician can't get real-time ADTs delivered, we're gonna have a problem. And if the patient doesn't have any idea how to navigate the system because there aren't easy choices, it's a you come to us scenario, we're going to have a lot of challenges. So I'd love to jump into, what do we need to do to create new generational norms? And so, Dr. Nana, you shared a little bit about that, but if there's one or two things that you think that's really going to strengthen these new norms, I think both for clinicians, I'll say clinicians broadly, and for patients, what do you think the remedy is?
Well, I think on this continuum of, how do we change? I mean, obviously, when you are so entrenched in how you deliver healthcare, whether it's based on, whether it's government or commercial payers, or it doesn't matter. I mean, the design is in place. So, how do you migrate, from something that's in place to whatever you're trying to get to that's new? And those of us, who are around the table here know that in healthcare, you don't flip a switch and everything happens. So it's really, I think sometimes it's to allow what we see in our clients, in our patients. Chris, I always say that, many times I am asked to speak on something in healthcare, especially in the African American community. Sometimes about high blood pressure, sometimes it's diabetes or whatever the case is. And when I'm asked to speak, I always speak what I'm asked to. But if I'm given the opportunity on how to talk to patients, I always say I want to talk to them about how to navigate around healthcare. Because, as I explore healthcare disparities, it's not the lack of knowledge of what to do. It's really the lack of knowledge of how to navigate in and around healthcare. And if you don't have an advocate that helps you do that, and it's not the simple, just the just these social, determinants of health. It's the idea that we live in a space where very few people really understand, how to get around. I spend more time on the phone talking to patients who know me as a friend or whatever, in the fact that they really do not understand this process of how to really navigate. It's kind of like, opening up your computer. At least, if you look at the keys, you can do something about it. But if you were to open, and look at the hard drive, we all would be, looking at whichever way. And that's what healthcare feels like. Patients don't have it. And I'll go to a second level. If you go to the average physician and you were to ask them to talk about how they navigate in and around healthcare, you would find that they're very, very limited in terms of an understanding of how things work. So in some way we have created, healthcare in a way, but we have lacked the knowledge of how to do that. It's I'm not Catholic, but I know you are, but I'll say it's kind of like we are pre-Vatican. We do not understand the language that we are speaking, but we know it's purposeful and it's meaningful because it's supposed to get us to heaven some way. And I think a large part of this, at least for me, that when I speak to people and when I talk to people, I find that if I can spend my effort helping them how to navigate in healthcare. Dr. Mckenzie, you mentioned something even about cost, right? I mean, I have long believed in healthcare that less is more and more is less. And I understand, the cost issues. But the reality is that for most patients, while they're in their house, they will look for a bargain, right? Or they go to Lowe's, or they go to, Menards, they would look for a bargain. In the principle of healthcare, we have not connected them to the idea that actually the really good things in healthcare is a bargain. And in particularly, I can say that in terms of, healthcare in the African American population, one of the reasons that it's so costly is because, the way we navigate around healthcare, usually when it's too late, or we navigate at the points that it's most costly, because things was not provided to us when we have the opportunity, we feel like we need to get them. And the reality is that if you understand, how to navigate in healthcare, actually more is less and less is more. And, so, I kind of think that if a patient really knows what that language is and they understand what that value is, I believe that they are smart enough to make good decisions like they have done in other areas of their lives and industry.
Sure.
Chris,
No,
I'd like, if you allow me to, just one comment.
No, please jump in.
The last 4 or 5 months, we've been immunizing folks in the community. We've been creating pop-up clinics. And the unique thing is we have retired physicians that are part of our team. And usually we'll have 6, 7 vaccination stations. But what has developed as a result of that, number one, we've addressed those that are here, as many would say, illegally. So we've been able to do that. We've helped thwart some of the issues in regards to human slavery, as I might call it. So we've gone ahead and thwarted some human trafficking issues. But the physicians and the advanced practice providers that are part of our team have really moved medicine and behavioral health into the community. It's a part of, let's check your blood pressure. So when was the last time you saw your doctor? And our problem right now is, since we're talking about IT and we're talking about access, we have no access to information in regards to that patient or that individual. And I think if we're looking at something that we're visioning for the future, and I think both Dr. Chopra and Dr. Mckenzie would probably jump in here, what can we do to take that record, to push it out so that when we do pop-up clinics, if there's another pandemic, those clinicians and those individuals that are sitting around the table and are providing care are going to be able to pull something up and say, hey, I see this, or I've noticed this, because we're all in the community working in the dark. And that also includes the work we're doing in the CCBHC model. We're getting those ADTs, but we don't get clinical information. We're not able to push out clinical information. we're still in the dark ages. So I guess I'd like to hear where we should be and what we should be doing in that type of a community environment.
Yeah, and Eva, that is sort of a great segue into our sort of our next topic, and I want to invite Dr. Mckenzie and Anish to speak to these behavioral norms. But there is, I think that's getting into the levers that payers and providers and policymakers and vendors can use to improve these things. So I think Anish, you were going to respond to that.
Well, and I'm happy to sort of tee off what could be a bit of a nice dynamic here.
Oh, I think you went on mute there.
Can you hear me?
Yes.
No.
Okay. So we've spent the last, let's say, decade or two running an experiment that our fragmented system should learn to talk together and to communicate effectively. And we've done so with two conflicting objectives. One is to open up as much information as possible so that Eva's comments that we can assemble that record and understand what's happening when the patient's in front of us should just work. But we've also tried to lock it down to say, well, under what authority are you looking at this? And where are you? And how are you figuring it out? And squaring a circle where you want to open up the record everywhere, but you have to double check who you are and why. We've struggled with how to build that. It's not a technical problem. It's really a governance problem, and it's a process challenge. I've been on the side of this debate to believe we need to flip the narrative. And the narrative is the one person that is legally entitled to universal access and to aggregate the record is the patient, him or herself. And we've never really had the muscles in these networks to communicate directly to the patient. It's been all these business agreements between payers, providers, network, And so Congress and the 21st Century Cures Act, frankly, in the Bush era, then Obama, then Trump, we're sort of multi-generational here on this. We've said, screaming at the top of our lungs, in HIPAA, a consumer has the right to their record. We just never built the IT muscles to say how and in what format. And we're finally there. As of next week, Blue Cross Michigan is obligated to make the patient's health record available to an app of the patient's choice. Over the next 12 to 24 months, all the health system provider networks will have to do the same. And we're going to have a common language for consumers to be able to aggregate their information. And unlike the opening up while locking down, which felt like you were competing in these policy objectives, opening up is a mandate. And all you have to do is learn to build that digital identity, which is going to be its own muscle. We're going to have staff volunteer to help. Hey, how do you get up a username and a password? And how can we establish? By the way, in COVID, we've had more usernames and passwords set up for testing and even vaccine. And you saw the state of California announced last week, every single person that got a COVID vaccination, including the undocumented, Eva, can use a mobile phone, Android phone, whatever they've got, and they can access with about 30 seconds of activity that proof of vaccination onto their device. So we're entering this era where the consumer is going to be the aggregator, which means who on this panel will sponsor that consumer service? Is it going to be Apple? Maybe. I love Apple. I'm a fanboy. All my devices are Apple. But I don't think it's big tech. I think it's going to be sponsored by Dr. Ned or a clinically integrated network that Amy helped facilitates that is earning that trust. And what I think we are right now, Chris, and this is the interesting dynamic, everyone who's listening to this webinar is probably thinking compliance. We are obligated to publish data to this amorphous concept of the consumer app. How many organizations have built the consumer apps to sort of be the recipient of? Most of the plans I've spoken to that have to go live next week barely got over the finish line to be compliant, let alone invest in the other side of it to be the app developer to pull it in. I'm curious, Amy, if you've got a skunkworks team working on it. But to me, I call this the era of health information fiduciaries. It's the digital Hippocratic Oath. It's the digital service that's wrapped with care management that says, if you trust me with permission to be your aggregator, I will provide you the advice you need to make sure that you're on top of your preventive services, that you're accessing the system in the most effective way, and that you're getting the follow-up you deserve. And we all have these, supercomputers in our pocket now, even amongst the most underserved populations. Let's put that resource to work so that we can help people properly navigate through the delivery system. Who will emerge as the most trusted health information fiduciary is what excites me about the industry. It's not going to be me. I'm not a vendor. I'm not selling it. But I want to partner with as many organizations who aspire to be, so we can support them with the open data insights for benchmarks. That, I think, is going to be the next 5 years to see the impact that we all expect. The final comment I'll make is, we don't need AI, blockchain, the future of everything. We know getting a patient who's just been discharged from the hospital into a clinic for 30 minutes to go through the discharge plan, to look at the meds, reconcile. This is not PhD in physics complexity. Yet less than 15% of all Medicare patients actually get this service. We're a decade into reforms. Only 15% of patients get a care transition visit after the hospital. Are you kidding me? This is pathetic. Okay, this is not, I need a PhD in AI. This is like, pick up the phone and come into my office. You just left the hospital. You need someone to explain this to you. We need a new muscle to encourage folks to facilitate that dialogue and to get them in. Anyway, we can go on and on for hours, but that to me is the opportunity as I see it.
Yeah, I agree with Anish. I think that he's raised some really great points. Governance over data is always kind of a challenge, and we balance this of, who needs to know and the protection for the patients, as well as making sure that we decrease fragmentation. I think we are really on the cusp of this continuing to evolve. It has evolved over the last 5 years, and it's continuing to evolve. I think the next frontier, as Eva is rightfully mentioning, and I also heard Dr. Ned mentioning as well, is that this community involvement piece is going to continue to grow as we try to manage patients, right? The majority of patients' lives are lived in the community, not in the provider's office. And so we're going to have to continue to figure out how we are also connecting those community-based services and providing that information to be able to close the loop on community referrals. But that's all, I think, where some of those public-private partnerships and insurance between policymakers and plans is going to be really important.
Yeah, Anish, I just thank you for saying what you said, because so many people get mesmerized by AI and machine learning and all this stuff, and we just need to get to first base and just get to simple data sharing. That's convenient and simple, right?
Can I make a simple one, because it's a personal pet peeve. Before I left the Obama administration, I had the pleasure of sponsoring what was called the $1 Billion Healthcare Innovation Challenge. We welcomed anyone in the public who had an idea that could change behavior, improve quality, lower costs. We'll test it like a clinical trial. We would create like an innovation trial. And we fielded 150 experiments. And the theory was, if the actuary of CMS looked at the results and found that intervention lowered costs and improved outcomes, it could be made available to everybody. Who was the first graduate of this clinical trial? The YMCA Diabetes Prevention Program. We fielded a 5,600 patient trial, and there was a 4-to-1 return on investment, meaning coaching people to stay healthy, reduce the onset of diabetes, and total cost of care was like $2,400 less. So the $600 voucher to YMCA saved $2,400 on average. And the actuary was like, this is amazing, high ROI, independent judgment, boom. In May of 2018, CMS, through the stroke of a pen, allowed every single doctor in every single community in every part of the United States to prescribe this $600 voucher to the YMCA. multiple millions of people had pre-diabetes would have qualified. Chris, as of the end of the pandemic 2020 math, how many patients per year actually got the voucher and went to the YMCA to get the class?
I hope a lot, but
Pick a number. Pick a number, Chris. No pressure.
low, million.
1,000.
Yeah,
1,000.
yeah. But
Now-
doctor, but there is something that needs to be stressed here too. That's a program that needs to be in a practice. So care teams need to learn how to deliver that. So we're not sending people out, but keeping them in.
Sure. There could be a million ways to
Yeah.
figure out what the response is. My point is, we know a really simple intervention
Yeah.
works.
Mhm.
We know the population it could benefit from. Let me ask even a simpler question. How many doctors know they can even prescribe it for their panels? How many doctors ask their staff to produce a list of pre-diabetic patients who qualify to send them a letter?
And Anish, I'll comment a little on this because I think I've seen this, I've faced it a lot, and around the issue of innovation. How to, where should innovation start? Who owns it? Who is going to disperse it? Who is going to make it readily known to everyone so you can have, utilization? And I think that's a structural problem that we kind of have in healthcare. I think the traditional way, and I'm just speaking as a practitioner, I believe, and you've heard me say it already, I think the patient is going to be where they have the vast knowledge in terms of what they want to get from it. But, in terms of where physicians has been placed, I think there is a historic concept around this that says that, hey, the way we drive ourselves are oftentimes, kind of the way we get paid, right? And to some degree, I know I have encountered many times with a plan, especially within Answer Health, when there is an incentive, and the purpose of an incentive is usually good, right? Because we want to achieve something, and we do the carrot or stick stuff so that we can move people along. But one of the things that I think practices are, especially when reimbursements are falling apart, the ability to survive in a practice is tougher and tougher. These incentive programs, become like a lifeline, So in other words, we have created an addiction in terms of how we behave and how we practice. That I think that is kind of a working against us. So there are many times I know as a practitioner, if I notice that the plan wants me to do something, I'm willing to go to the plan and have a conversation about what is it you're trying to get to? What is it that you're really trying to achieve? Because many times, I think there are a lot of physicians that follow things not knowing the real purpose. Or sometimes the purpose might just be the carrot or the stick issue. Well, the question is sometimes, tell us, or let us have a conversation of what you're trying to achieve. And one may be surprised, about the innovation that can exist in that practice in terms of saying, if you're trying to get pre-diabetic patients, into a place where we can make a difference in their lives, boy, I can really innovate. And, I don't mind you measuring me, and I don't mind you telling me what I need to achieve, but kind of loosen, the shackles, and take the guardrails out and let me, within the context of what's legal and obviously compliant and HIPAA, et cetera, let me innovate in a way to bring the result, and let that kind of be the dominant kind of a viewpoint in terms of how practices can really respond. But I think what we have trapped ourselves in is here's what a health plan may require of us to do. And we put all our energies, we make our staff be aligned to that, the flows and stuff that we put into practice to meet that purpose. Not that it isn't a good goal, but I think you're only getting half of the stuff. You raised your Apple phone and says, you have a supercomputer in your hand, but you're using it just as a phone, right? That is what I think we are not optimizing what we can really get from practices, because we are limited ourselves to just follow the incentives that are before us. And they'll get us half of the way, or they may get us 1/3 of the way. But we are missing opportunities, I think, if we don't go that extra mile and saying, how do you innovate? Because all healthcare is local, as you said, and to some degree, it's local in terms of the relationship that you have with those patients.
So I'd like to answer the question as to how many doctors know about DPP, because I think you need to know that in Michigan, the Michigan State Medical Society had that as part of their training at annual symposia. The Michigan Osteopathic Association did as well. There are certain POs, physician organizations like Medical Network One, that sat in with the CDC, did become DPP providers. So to your question, the answer is yes, there are people out there that are engaged and that are attempting to move that needle. It's not simple. You've given us a big task. We've gotten a lot of support from PGIP, but we'll continue driving it because we want to make you proud as to what it is that we've accomplished in Michigan.
Well, maybe we'll turn it to Mckenzie, but if Amy on this issue, but if I could just flip it to the narrative of the telehealth scenario, okay?
Yep.
So just let's connect a few dots and then paint a picture of what could be, and then we'll come backwards. CMS last month launched a new program called direct contracting. I happen to be a fan of it. I know it's a little bit of a controversial subject, but it's going to create a lot of disruption in the market, in my opinion, positive disruption.
Agree. Yeah.
So let's talk through what's going to happen, in my opinion.
Okay.
Normally in this move to value-based care, and Chris, you teed it up in the questions that you asked about behavior change and how to get physicians on board. And I would have said last year, if we wanted to move to value, the engine of change would be physicians who wish to take on a new payment model, maybe working with Amy to sign up for an agreement that says, incentivize me to do the DPP outreach, et cetera, and I'll do it. And Dr. Ned, you kindly said, I'll work with you, let's figure it out. We've had a decade of this payer-physician discussion, and the patient was sort of secondary. No disrespect, but mathematically, that's how the models worked. It's called attribution. Patients just auto-enrolled. If their doctor said they're in, the vast majority of patients, if you ask them, hey, are you in an alternative payment model? They're like, what are you talking about? I don't know what that, I mean, I can see my doctor. What is this? What direct contracting can do, and I think will do, and where telehealth comes in is, we now have a national platform for competition. A direct contracting entity can market to a patient in Detroit who may or may not have an active PCP, who may or may not be involved in the various permutations of value-based care, but say, you know what? I want to be your Sherpa. If you confirm my network for free as your primary quarterback, you get to see any doctor you want. You can go anywhere you want. It's original Medicare. You have your legal benefits, but name me as your Sherpa. We'll check in from time to time, likely virtual. Okay? We're going to communicate with you. We're going to intake your vitals. We're going to intake your health record history. We're going to understand your challenges. You're pre-diabetic. We have found that there's a YMCA 12 miles away from you. We'll facilitate you going. I believe the excitement on telehealth is this intersection of three competing forces. A business model like direct contracting that allows the patient to give their capitated premium to the virtual program, $13,000 a year, just by what's called voluntary alignment. So step one. Step two, that better be a fiduciary and not a shady, inappropriate, put him in jail bad guy. But if it's one of the good guys, then this will hopefully ingest information, either the interview with the clinician or survey assessment or integration of the medical record, the ADT feed, Chris, you name it, and organize it to give you decision support. And then obviously blending virtual in-person so that it's part of a care team. Maybe all of the care is virtual for primary care. Maybe it's sort of triage primary care and they route you to more advanced practitioners, like a geriatrician that can treat the frail elderly or someone else. And the interesting thing to me is every provider that operates thinking that my competition is the other clinic down the street, finally we have a mechanism where someone can come in and say, you're not really doing the right thing. And as much as you're trying, Eva, you're doing the lessons, you're getting your training, you've been to the medical society, I don't care. A few hundred people in all of Michigan got the service. It's a failure, period. Trying hard doesn't mean outcomes worked.
Right.
We need to bring new muscles, and the direct contracting program at CMS technically and legally creates, I think, a phenomenal vehicle for this to happen. Now we'll see. It's not a vendor-led thing where I'm just a telemedicine pay-per-click, service. That's not going to do much. It's got to blend the coordinated care, the value-based care, the decision support, and the routing that come from, basically saying, if you know as much about me as anyone else does, tell me the 5 things I need to do to stay healthy.
Yeah, Anish, I agree that direct contracting is a game changer. We're still waiting to see, is CMS going to expand the initial territories? Are they going to stick with those initial territories? And it does put the power in the patient's hands to choose as to kind of where they're going to go. And I think that it's going to bring in new innovation, both from a plan side as well as potentially others that are going to come into the market. And to Dr. Ned's, earlier point of, we've been on this journey of value-based of like carrot stick type of thing. I think there are opportunities now to continue to evolve that relationship in terms of that shared accountability, right? Which allows providers to innovate, but then there's also the shared financial accountability as well as the quality benchmarks to help us kind of understand and make sure that those populations are performing. I do think that, for physicians, I'm a physician as well, there has been this feeling of like, there's so many things for us to do, right? The way through that is closer partnership, tighter partnership, and shared accountability between payers and providers.
So let me just add to that. So our organization is comprised of independent physicians. We don't have access to venture capital funds. And most of the DPC folks come from the venture capital world. Those solo and dual practitioners who have moved into the patient-centered medical home model and into the neighborhood will not be able to compete with, and I will list them, with the Village MDs, with the Oak Streets, with the Chen Meds, and with others. So unless we come up with a solution to help really excellent clinicians that do not have the same type of ability of trading on the stock market, then we need to come up with a solution for those that are good clinicians without the financial backing that truly is provided by some of these large vendors that are coming to town.
You have trust.
Yes, we have trust.
So talk to Amy. In my opinion, trust wins. If you go to the neighborhood and say, look, I don't know who your main primary care doctor is, but pick me. I don't know who these other folks are, but you know me, trust me. Mm-hmm. You just need help on the back end to manage the things. You don't think Amy would want to get into that? And if she's not, I can give you 10 other platforms that would love to do that. They would do that in a heartbeat. This is a no-brainer. It's the single biggest opportunity. And, for sure, all you have to do is raise your hand. We're working with a bunch of small little group of doctors that have no money that are just saying, hey, we want to take on this responsibility. We got a group that's launching in Wards 7 and 8 in Washington, D.C. That's the most underserved part of the district that has no resources. And they're doing it like they're putting a kiosk in an African-American barbershop and they're trying to get folks to sign up. Mm-hmm. You don't need venture capital. I mean, for sure, people that I love them all. They're all my customers too. I love Village. I love everybody. We have 95 customers and I run the gamut of people that I work with. But my point is, it's going to come down to what's the piece of paper you put in front of the patient to say, I want to be your quarterback. And that, in my opinion, the more doctor groups who say, I want to take responsibility for total cost of care, Amy said it, we need that payer-provider collaboration. Medicare is basically saying, take the entire expected spend and manage it. And you might need reinsurance and all those sorts of things, financial things, that people need to backstop you. And again, I'll happily take calls from Chris. I'll connect you to people who would sign you up yesterday if you raised your hand.
And I think, Anesh, conceptually, I think the idea that you raising, I think it is an important one. I think as you were saying it, I was thinking about, I just had surgery a few weeks ago, and I've gotten probably about 5 calls from 5 different groups, right? From the hospital, the health plan, care manager, through my physician practices and so forth. And each of them had a separate nuance, right? And part of that nuance, I believe on the opinion, there is the issue that they're concerned about me and they want to have the best outcome for me. They also want to make sure it's, their cost is managed appropriately because there is incentives that are tied to that. But the messaging was very different from each one, right? Because, the way their orientation to this is really based on, what are the levers that they need to pull so they are compliant with what they need to be compliant about. So it's one of those things where somebody's trying to do something good for me, but each of them have different levers that they want to pull that's purposeful for them. Now, the idea of what I think you're bringing in, it's a really good one. The question is that, okay, is there a central person that takes that role, that they can do on my behalf or on any other patient's behalf? And that's where it comes down to, and I think you were kind of was, pointing to that, is that at the end of the day, if we have the trust relationship, we kind of wanted to work through that trust relationship to get more mileage from what this is. Because I have no problem. I would love to get to a point where you go to see a doctor, and Chris was talking about norms and behavioral change. I would like when we get to a point where you have your first visit with a patient and they go through all the steps and stuff that says, you will be getting a call from here. We will be doing tele visits and you at this intervals. We will be doing these things and you and that interval. So there is an expectation that I think normative behavior, it's about that. When I fly in the airline, when I get a train ticket, whatever I do, there is an expectation that I have that what happens next, what happens, whatever. And that's what I think is lacking here. If I just put, one person that takes this on, it's another level, and who knows, it may take over because, CMS has a bigger, bully pulpit and they have a bigger horn that they can really blast it out and it can become normative behavior. But I think I'm getting back to this, is to say that how do we, in the trusted relationship, put in the expectations so that patients knows, if you are in this category, when you have an encounter with me, here is what's going to happen for the rest of the year. Here is who's going to call you. Here are the expectations there. Here's what's going to be.
Yeah, and I want to make one friendly amendment, Chris, before I miss it. There are really 2 programs that CMS launched. I want to make sure I clarify my statement. For doctors that have existing patients where they already have a relationship, that version of direct contracting looks a lot like the traditional ACO model, where you have to beat your own performance, and there really isn't the voice of a patient. That's just the same thing with more risk. And people are saying, yeah, no, maybe that's a different animal. The point I'm trying to get at is that it's about the voluntary alignment, the new patient that Dr. Ned just said. I want to build a better service for someone I don't know, but who knows that they can trust me. And that's where the economics are right for someone to do a better job. When I describe this virtual first, it's that new patient that you've never met before, where you set the new norms. That's what this CMS program allows you to do that has never been done before. What's called paper-based voluntary alignment, where they can stroke a pen and say, I want to sign up. I'll give you one final statistic. In the west side of Chicago, where the life expectancy is 17 years shorter than in the rich part of Chicago, only 17% of the dual eligible population is enrolled in accountable care versus 34% nationwide. Half the people who need coordinated care the most are half as likely to get it in the worst parts of Chicago. And I bet you if I ran that report for Detroit, it would be the exact same thing.
I agree with you that, and I think in a lot of the population that you mentioned about, actually, they use this pretty good. They are really good at utilizing social media and all of those kinds of stuff like that. And I mean, you know that when the social media stuff started, there were a couple of giants that were in the industry, but we kind of soon realized, hey, we can migrate to a lot of different platforms that can get us to the same place. If we want privacy, if we want them to not hold on to our pictures, if we want them to not share, I mean, we can do anything, because it's just a really broader field. I really, I think in these populations, and Chris, I know you talked a little about that earlier, is this idea that I can have this intimate relationship here. I would love, that if a patient has an expectation that they come from a practice, that, if you happen to be diabetes and you have insulin or whatever it is, that somebody is nudging you by an agreement, that you have, that I will take information, I will take text, I will respond to text, I will do those things, that can happen wherever I am. So, whether I'm at a restaurant and, a meal comes up and I'm trying to think about, what's the little adjustments I can make, I can send a text to somebody and they can say, hey, here's what you do, or here's what you do. Those are the kinds of stuff that, patients have to get to the point where that is becoming normative behavior, like going to any bank and put in your bank card and get something out of it. I think that is the kind of norm and behavioral change that I think we really want to get to, is to say, we have tools here. How do we use it in the appropriate way? And if you get to a point where this texting doesn't work and it gets to a critical point, you can switch it over to a provider, your provider or some representative of your provider who is going to really, be able to, to in that time and in that moment, make the proper recommendations. So the idea that you have to be seen in the clinic, I mean, if we're not batting well in these populations now because they don't show up for whatever, and trying to do the same thing over and over, I mean, we all know what that definition comes down to.
Yeah. I think this is a great segue into our breakout sessions. One is going to be talking about interoperability and the consumer access. The other is going to be talking about remote patient monitoring. Both of these serve a purpose of patient literacy and patient access. And I think we're going to have another challenge in the future with remote patient monitoring. I don't think people are, maybe some are looking out towards that. The RPM is starting to get popular, right? But we're going to have data coming in from so many different sources. How are we going to aggregate that? How are we going to turn that into an important objective data point that can spawn off a subjective assessment in real time to that patient? You gained 5 pounds in the last 18 hours. You've got CHF. How do we ping you and deliver that package to the clinician? And when we think about telehealth, for me, it's not the fancy video screen that gets turned on. It's about, I want to be able to put all the packet of my information, of my request, of my concern into one packet. I want to send that packet and not have to think about it until the clinician reads it, reviews it, and responds thoughtfully to it. I don't want to wait on hold. I don't want to talk to an office manager, a care manager, and wait for the care manager to talk to the provider, and then try to call me back and wait on hold. That's where I think some of these efficiencies will be great. And I'm glad to see from your conversations that the work that we're doing at MiHIN is right on track for all those things. Thinking about this program and projects like coordinating the care coordinators, knowing who the quarterback is and knowing who the team is that's helping, having tools like the interop station to be able to help payers convert that data to FHIR resources so third-party apps can do it. And then last point, I'm going to put a plug in for the electronic consent management service. That's a big deal that I think is going to allow us to leverage all this information, so that if a patient downloads information from multiple payer sites they have relationships from multiple EHRs. I have my data in 5 EHRs. I'll never go to the patient portals ever for it. They're clunky and it doesn't do me any good. But if I can pull all that together and then I can share it with my clinicians, for me, that is value. So our time has ended. I wish we had another hour. I think we could fill a couple more. We're just scratching the surface. So I want to thank all of you. There were some questions, but I know through the conversations you answered them. So I appreciate everybody participating, and thank you for your time. I know you have busy schedules, but if you have time to hang around for one or two of the breakout sessions of interest, I think there'll be some great dialogue, and hope to in the future maybe be on stage with you somewhere instead of virtually. So thank you all.
Thank you.
Thanks, Chris.
Next up, John, if we could throw the slide deck back up. Let me get a look at our next steps. I'm going to introduce the breakout sessions just before we go to break. The speakers we have who will be participating in those breakout sessions, we're going to have one that's is entitled Clinical Innovation Supporting Value-Based Care, Telehealth, and Remote Patient Monitoring. You heard a lot about that. This session will be, again, participatory. We want you to speak up, ask questions, put your comments out there. The other one will be consumer health and interoperability. This is really the idea of consumers having access to their data to improve their knowledge and their literacy of their conditions, as well as be able to have a longitudinal, thoughtful conversation with clinicians based on their complete medical record. So those will start at 10:45. But before I do that, I would like to introduce our speakers. Just make sure I get this right. So Sharon Kim. Sharon is, and we will be jumping to Hopin, but I just wanted to make sure you know who's going to be there helping you facilitate this conversation. Sharon Kim is a healthcare manager at Blue Cross Blue Shield of Michigan. Her team supports health information exchange, telehealth, and palliative care initiatives under the Physician Group Incentive Program, otherwise known as PGIP. She also serves as a board member for the Michigan chapter of HIMSS. Sharon will be speaking with and co-leading with Shreya Patel. Shreya is MiHIN, our attorney, focused on areas of healthcare and privacy. Her role as Chief Policy and Privacy Officer for MiHIN. She routinely examines the effect of national and state initiatives on interoperability and participates in national dialogue surrounding the Trusted Exchange Framework and Common Agreement, known as TEFCA, and the final interoperability rules from the Office of National Coordinator. Shreya is an advocate of balancing the public health interests of greater information sharing with patient privacy, and in turn leads statewide efforts surrounding sharing of behavioral health information and electronic consent solutions to provide healthcare consumers with the ability to receive quality coordinated care in a secure method. That's a long way of saying Shreya reads the really difficult text and documents from the government and translates those into things that we all can understand and build strategies on. Lee Marana. Lee is a healthcare professional with 12 years of experience in strategic planning, innovative program development, program management with a fast-growing managed care organization and dynamic nonprofit hospital network in the Upper Peninsula. He currently serves as a president-elect of the Michigan HIMSS chapter and enjoys coordinating professional development and educational opportunities for health IT. He is now the full-time manager of HIE and informatics at UPHCS and UPHIE, Upper Peninsula, focusing on further advancing HIE, telehealth, remote patient monitoring, and health informatic initiatives. Lee wears many hats and is able to speak in so many different languages around HIE, remote patient monitoring, telehealth, and he's a great advocate. So we will jump into those sessions at, I believe, let me just check the time to make sure. We will be jumping into those sessions at 10:45. That gives you about 10 minutes, and look forward to seeing you in a few. Thank you. Welcome back. We are going to jump into some review on the breakout sessions. So if you have the notes, we'll pull those up. Great. So first, you're going to hear from Lee and I on the workshop notes. You know, half an hour is not a lot of time to cover the whole conversation, but we did share a few things that if you were in the other session, I think are good to know, and we did get some good points from folks in the audience speaking up. So our session was regarding telehealth and remote patient monitoring. And sort of laying out the landscape like Anish did and Dr. Ned and some of the others, the landscape is changing, as you know, right? It was 2016 when providers said, no, we don't want to do telehealth. We're just going to outsource that to a national telehealth vendor, like the Amwells or the MD Lives, because they didn't want to impact their productivity, office visit productivity. Well, times have changed, and since then, now all providers need to have that digital brand available to their patients. And so I think in the same way, one of the things that we see with remote patient monitoring is there's an opportunity out there for auxiliary staff, outsourced vendors to handle all the remote patient monitoring, everything from the complexities of identifying which populations need it, which tools they should use, which vendors they should use, providing those services and getting information back to the PCP. But I think increasingly, this is the item that Anish talked about, that how does a provider get to know the patient as well as they can? And so I think it's going to be a huge opportunity. One special thing I want to also call out, because I talk about it all the time, and when I heard it played back to me in a different way from Lee around social determinants of health, we certainly know that SDOH results are they're essentially like a lab result, right? They're objective problems. They're not subjective feelings. They're objective problems. And like a remote patient monitoring device, checking your weight on a regular basis or glucose, we really ought to think about SDOH as remote patient monitoring, but just for a different data point. And so this will be I'm really looking forward to the work that we're doing here at MiHIN around social determinants, the work we're doing around remote patient monitoring, and I think some of the key takeaways that Lee's going to go over will move us into a new direction. To first understand, how complex this is going to be to manage this and get to know our patients. So, Leah, I'll turn it over to you to kind of share what we talked about in the breakout.
RPM, obviously, to start that intervention with care managers and healthcare workers and the patient is the first step to kind of see those auto range values so they can be proactive instead of reactive, to prevent patients of showing up at the ED, and just keeping that communication loop hand in hand with the healthcare providers along with the patients themselves. So that's the first step. But then we kind of talked about, what kind of data do we actually want included within the longitudinal record in terms of, that care coordination piece is the first piece, but then what important information do we want for predictive analytics from these RPM devices for population health reporting, clinical quality measurement to actually get the whole picture of the whole patient. So those are some things of the future, but one thing at a time. Obviously, we need buy-in from the patients and retainment of the patient and compliance. Some of the things that we're working on within our pilot are some incentives. You could either give gift cards out. We're actually giving the patients within our pilot the Garmin smartwatch. So they'll actually get it at the end of the pilot. So that's an incentive for them to be compliant and actually utilize it going forward. And it's a good sustainability model, to keep on using those devices going forward with the clinic. Obviously, the biggest challenge is, the technology gap between the telehealth app and RPM. We can have all the technology in the world, and you all know that, but we need to incorporate it within the clinic and hospitals' workflows and integration, right? So we look at these remote patient monitoring companies, they're going to have to act in the same manner as these EMR companies in terms of interoperability with the data sets. And we have all the data in the world within healthcare, we need to make that meaningful information so it's pertinent at the point of care, for the healthcare workers. So, but we also need those in the data lakes, right? Going forward for predictive analytics and population health reporting as well. So those go hand in hand. I talked about the interoperability piece is really key. Within our telehealth app, that within our pilot, the healthcare providers can actually receive the MiHIN statewide use cases for ADT alerts and discharge summaries. So that's ideal. And we kind of talked about the future of telehealth and RPM, the asynchronous communication that relies on AI and machine learning. So a lot of this stuff is going to be automated, not to take jobs away, but the healthcare workers have enough to do to take care of the patients, right? So automating those processes and following up and closing the loop for patients, even if it's a text message or an email based on, auto range values. So really cool stuff that we're deploying, and the technology's there. We just we need everybody involved, the providers, the payers, and the patients, all need to be involved in this process to make things work efficiently.
Yeah, thanks, Lee. I'm back. Sorry, I had to laugh there. That was a technology fumble on my part. So hopefully you can all hear me now. Lee, I can hear you. So thanks for giving the key takeaways. I don't have anything else. We can certainly move to the next session. If there's anything else you want, unless you want to add anything else.
I was just going to add, we have a lot of different opportunities in terms of, it seems like patients really want to see familiar providers that they're comfortable with and they've been a part of for several years. However, in rural areas, we might not have that necessity, right? In the UP, there might be a need for mental and behavioral health services. So that's really where the telehealth and RPM can come into place. To kind of even outsource that outside the area. You hate to see somebody, sitting within a 6-month waiting period to get in, right? That might be too late. They need those services now. So that's another opportunity that is really beneficial with this technology.
Yeah. Great, thank you. Jonathan, happy to segue to our next breakout session. As I missed it, I'm looking forward to hearing about it.
Yeah, thanks so much, Chris. So if we're able to pull up the notes from our session, then we can kind of start to run through some of our key takeaways as well. So first thing I'll say is our breakout session probably could have gone another 30 minutes to an hour. I think we kind of just grazed the surface. But just to give a little bit of a summary to those who weren't able to attend, our breakout session was to examine how the healthcare consumer is taking on a larger role in the landscape. I kicked things off with a little bit of a refresher on the recent interoperability rules, particularly related to the CMS patient access rule, and then any complementary language in the ONC final rule. And then we kind of opened it up to the group to hear their thoughts and their experiences with this kind of transition where the consumer has a little bit more access to information, control over their healthcare information, and so we just discussed the advantages and maybe some of the gaps or where we could still have a lot of area or room for improvement. So just to kick things off with our first takeaway, one of the first things that our group discussed was this patient-centered approach. And what we said is that the patient-centered approach on how we should be delivering care is a really powerful model because right now patients are kind of living in this gray area where all their information isn't being shared across the space. So something like the CMS patient access interoperability rule, that is going to really make sure that patients have access to all the information that they need in one location. And that's going to be a really powerful thing and a move in the right direction. We did a little bit of a departure from the advantage, and we talked about one key problem that comes with patient access, and that is this point that patients do have access to the information, but that doesn't mean that the information that they have access to is actionable. So for example, they might not be able to understand all the information that is coming their way through the mobile applications, and the only way for patients to truly understand that is for the information to become curated or kind of filtered down. So they're really receiving the information that they want to know and that they need to know, as opposed to maybe just all of the content in general. The kind of example that we like to give when we talk about that conflict is, you can receive all of the values for your lab results, but are you actually able to understand what it all means, or do you actually need the provider's dialogue to go hand in hand with that information? So that was probably about half of our discussion, and we did talk about things like patient education and this idea of data rich and information poor. So you might have, so much data, all of your healthcare information at your fingertips, but is that giving you more information or really empowering you? So we were talking about a little bit of the disconnect there and kind of strategizing on how to resolve that in the future. So on the solution piece, one thing that we talked about is, well, what is the solution to that? And I kind of touched on it a couple sentences ago where I said that, the apps can curate the information or filter the information. They can make it a little more easily digestible or kind of bring down the health literacy level for patients so that they can really understand what it is that they're looking at. But then that kind of begs the question on, are the apps truly responsible for taking on that piece? And if there is any sort of miscommunication or misinformation, where does the liability fall? I know a few members of our group said, well, the liability for actually interpreting, curating the information and getting straight to the point so the patient has like the key takeaway that they need is essentially with the provider that might order, like let's say the test or the image that the patient has access to. So you might have to go back to, the original source or the original provider that actually requested the information, rely on their interpretation, and then only have that sort of dialogue be what's reflected in the app, as opposed to having a situation where maybe a patient receives an image and then they're relying on a separate provider to actually read that or interpret what is truly going on there. So that was a conversation that we are just kind of grazing the surface on right before our session ended. So I'm sure that there's a lot more that we could say in that area. But the last thing that I did want to touch on in our group is just this idea of mobile applications and the responsibility that they have. And the reason for that is that mobile applications are not subject to HIPAA unless they are sponsored or owned by a covered entity. So we might be giving them a lot of room to do these specific curation and to do this filter piece for patients, but we don't really have any control, or we kind of lose that control and that patient protection once it leaves, let's say like the payer and goes into the mobile application. So that's another thing to just kind of be cognizant about. And then I know that one final thing that we talked about just in relation to the CMS final rule was this idea of ADP handoffs. And so earlier this year, I believe in May of this year, one of the CMS mandates went in place, and it basically required all hospitals, inclusive of psychiatric hospitals and critical access hospitals, to send ADP messages. And our group said that that handoff or that required notification is going to be particularly important to close a gap in care coordination, particularly in the ER space. And we didn't quite get there yet, but I think that the next kind of natural progression or the next conversation would have been, how can this kind of be moved into the patient access space and the telehealth space as well. So perhaps, there would have been a scenario in which once a provider receives like an ADT message that the patient has been admitted to an ER, they can take action within, one of those mobile applications and maybe even set up like a telehealth visit with the patient. Again, we just kind of grazed the surface, but I do want to give Sharon the opportunity to kind of fill in any gaps or anything that I missed, or just speak more generally on our breakout session.
Thanks, Shreya. I think you covered everything pretty well, very comprehensively. Just a couple of things. I think we were all just really, really excited about the opportunities here. We've talked a lot about the patient being at the center of healthcare, but making the patients the actual gatekeepers now of their health records is just such a huge conversation and such a huge step towards that patient activation, patient empowerment piece that I think we talk a lot about in healthcare. To Shreya's point, we discussed, that comes with a lot of education, right? And making sure that the patients understand exactly what the data means. And these rules are designed, I think, to kind of increase innovation, increase competition. So by having this environment that where patients have more choices in their healthcare, have more choices with these third-party apps. But I just want to reiterate something that Lee and Chris mentioned that came out of their session that we discussed a little bit too in ours, is the collaboration piece. There is, again, so much complexity that's going to be around kind of implementing these rules. And we need to do that, and we need to figure that out, how that we're going to do that in a collaborative manner. And I think that's something that we as a state, we do particularly well compared to other states, right? We have a lot of kind of avenues, whether it's PGIP, whether it's kind of the MiHIN work groups, to be able to talk to each other, make sure that the way we're rolling this out is, again, to the true benefit of the patient. So I'll be really excited, I think, to see what we are able to do moving forward using that type of approach.
Great. And then I think before we hand it back to Chris, I will say there was just one thing that I forgot to include on our key takeaways when I was consolidating them between sessions. And then that was this discussion of consumer-mediated and consumer-directed exchange, as opposed to having the individuals interpret all their information on their own. And the reason that came up is around if patients are receiving a plethora of information on their own healthcare, one question that we might need to ask is, do they want all of that information, or do they necessarily just want the control to say, I want my information to go from this provider to another provider, and I want to be able to coordinate my own care, but I don't necessarily need to be able to interpret or read through all of my information on my own. I just want to make sure that all of my treating providers have access to the same information. So I think that's like another thing that we might want to consider, and that might be a dialogue that's worth expanding on. I know that over the past maybe 2 years, the conversation has really revolved around, the patients really understanding their information and really having access to their own information on their phone. And I think that is an amazing and a very powerful thing. However, there might be a lot of situations where individuals might not necessarily need that level of detail, and they just really want to make sure that the coordination is happening at that provider level. So that's kind of just the final thing that I'll say about that piece before we hand it back to Chris.
Thank you very much. That was great. I wish I could have been in it. There is so much to talk about there. This is just, I think, the beginning of the conversation. As we heard from Dr. Wingen and the panel, and then each of our breakout sessions, there's a theme here that this conversation needs to happen with multiple stakeholders in the room. and that without that, we're not going to, the cake's not going to bake. And I think there's a lot of things that, as I was hearing the speakers, a lot of things were resonating that, we're doing a lot of things right here at MiHIN with regard to the interoperability technology, the consent management, the SDOH. And then we think about how pivotal Acres is to so much of this work when Anish is talking about identifying your own patients to your own panel and value-based care. These are all sort of cornerstones of what we're trying to do to support care delivery. And we are now entering that next phase, and we're at that crossroads where now this is really going to touch consumers in a whole new way. So, and that's really why we started this session with talking about behavior change and generational norms, how we change patients' expectations and providers' expectations, and how we use different levers, be it policy or payment models or clinical workflows, technology vendors to help us get there. So I appreciate everyone's participation, attendance, and presence in this. We are, about 20 minutes ahead of schedule, so that's going to give you hopefully a full lunch break. Before we do close, I just want to make sure you're invited back to the next sessions this fall. This whole strategy was to sort of break up the conference into nicely digestible components, and unfortunately, it probably would have been better to get together. I think this was an excellent format for digesting all of this material over time, and it's given us the ability to sort of go deeper over the quarters of the year. So coming up on October 12th, I just want to make sure everyone's aware, there's going to be the final eCMS workshop, and that's the electronic consent management service. That'll be a great event, and as you heard from Anish, that's going to be something we need to solve for in the future. After that, November 9th, we will have the final Cornerstone Conference. And so stay tuned to those agendas. Those will be coming out soon. Just want to thank, as you see, all the sponsors here for making this happen. I want to thank the panelists who took time out of their day to do this, as well as the folks who put this on, the folks at Motown Digital, as well as Katie and Nazi for getting this accomplished. Thank you.